Hi everyone! Thank you for inviting me to present this session on basic cardiovascular system anatomy and physiology. My name is Lisa Parker and I am a full-time assistant professor in the Health Information Management Department at Rowan College at Burlington County. So this presentation is going to cover some basic anatomy and physiology of the cardiovascular system. Here's some basic heart facts. The more education you have, the lower your risk of heart disease. This came out in a study done in 2017 from the British Medical Journal. Just an interesting tidbit. A normal heart valve is the size of a $50. The heart beats approximately 100,000 times each day, and that's assuming a heart rate of about 70 beats per minute. Each minute, your heart pumps about 1.5 gallons of blood. Heart cancer is very rare because heart cells stop dividing very early in life. So this refers to heart cancers that are the primary tumor site, not metastasis to the heart. The primary function of the heart is to pump blood through the blood vessels and provide every cell in the body with oxygen and nutrients. That's about 75 trillion cells. And just a fun fact, the only cells in the body that don't get blood from the cardiovascular system are the corneas. The size of the heart is about the size of your two hands clasped together, and overall it weighs less than a pound. And the heart is located in the middle of your chest in the cavity called the mediastinum. So let's talk about the size, the location, and the orientation of the heart. So like I said, the heart is about the size of your two hands clasped together. It's a hollow cone-shaped organ, weighs a little bit less than a pound, about 250 to 350 grams. It fits within that mediastinum, which is the middle or medial cavity in the thorax or the chest, and it sits kind of obliquely or diagonally, somewhere around the second rib to the fifth intercostal space. It rests on the superior or top surface of the diaphragm and lies anterior to the vertebral column and posterior to the sternum. About 2/3 of its mass lies to the left of the mid-sternal line, and the balance of it, or the rest of it, projects to the right side. The lungs lie on either side of the heart laterally and partially obscure the heart. The broad, flat portion of the heart is referred to as the base and is about 9 centimeters wide, and that is directed towards the right shoulder. The apex is the pointier surface of the heart, and that points inferiorly towards the left hip. If you press your fingers or palpate between the fifth and sixth ribs, we call that the fifth intercostal space, you can feel something called the apical impulse or the apical pulse, or sometimes we call that the point of maximal impulse or PMI. That's where you can feel the apex of the heart, or the strongest pulse point of the heart. That's where the apex is closest to the chest wall. So let's talk about the layers of the heart now. We're going to work from the inside out. The endocardium is the innermost layer of the heart and is a continuous sheet of endothelium. And if you remember from your A&P days, that is the layer of connective tissue that covers and lines structures within the body. So this layer of connective tissue lines the inside of the heart, and it is continuous with the valves and blood vessels within the heart and the blood vessels that leave the heart. The next layer is the myocardium. Myo means muscle, so the myocardium is the heart muscle. It's composed mainly of cardiac muscle and forms the bulk of the heart. This is the layer that works. This is the layer that contracts and pushes the blood through the heart. In the myocardium, the branching cardiac muscle cells are connected to one another by crisscrossing connective tissue fibers and arranged in spiral or circular bundles. And these interlacing bundles basically link all the parts of the heart together. And these connective tissue fibers form a dense network that we sometimes refer to as the cardiac skeleton, and it reinforces the myocardium internally and anchors the cardiac muscle fibers. The network of collagen and elastic fibers is thicker in some areas than others. For example, it constructs these rope-like rings that provide additional support where the great vessels, that's the aorta and the pulmonary artery, for example, protrude from the heart and around the heart valves. Without this support, the vessels and valves might eventually become stretched because of the continuous stress of the blood pulsing through them. Additionally, because connective tissue is not electrically excitable, the cardiac skeleton allows action potentials to spread only through specific pathways in the heart. The outermost layer is called the epicardium, and this is the thinnest layer. The epicardium forms part of the pericardium. So epi means upon, on or upon. And the epicardium forms part of the pericardium. And pericardium is the sac that surrounds the heart. So here's a picture. We're going to talk about the pericardium in just a second, but here's a picture of how all these layers are connected to one another. So the endocardium, again, was the innermost layer. The myocardium was that thick muscular layer that contracts and works to push the blood through the heart. And then the epicardium is continuous with the pericardium. So the pericardium, think of the pericardium as the sac that surrounds the heart. And it has two basic layers. The layer that sticks to the heart is called the visceral pericardium. Visceral means organ. That visceral pericardium is the same thing as the epicardium. So the layer of the pericardium, the layer of that sac that sticks to the heart, is called the epicardium. The next layer of that sac is called the parietal pericardium. That's the outer layer of the pericardium. So there's a layer that sticks to the heart, and then there's an outer layer called the parietal pericardium. And that parietal pericardium anchors the heart to its surrounding structures. And in between those two layers is a space called the pericardial space, and that space is filled with pericardial fluid. So here's another picture. So there's a layer of that pericardium that actually sticks to the surface of the heart. And the layer that sticks to the surface of the heart is called the visceral pericardium, which is the same thing as the epicardium. So the visceral pericardium and the epicardium are the same structure. Then there's a layer of fluid, and then there's the parietal pericardium. The purpose of the fluid is to reduce friction. Remember, the heart is always beating. The heart's always in motion. Remember, I said earlier that the heart beats 100,000 times per day. So the heart's always in motion, the heart's always beating, and it's always moving, so it's going to build up friction. And the purpose of that fluid is to reduce friction. So let's go back to this slide. So the epicardium is the same thing as the visceral pericardium. That's the layer that sticks to the heart. The parietal pericardium is the outer layer, and that is going to hold the heart and anchor it to the surrounding structures. The space in between those two layers is filled with pericardial fluid that reduces friction. Now, surrounding all of those structures is something called the fibrous pericardium. And the fibrous pericardium is composed of fibrous connective tissue that is not stretchy. It's a tough, dense connective tissue layer that has three purposes. It protects the heart, it helps to anchor it to surrounding structures, and it prevents the overfilling of the heart with blood. So it maintains its size. It doesn't allow the heart to swell and fill like a balloon. Okay, so let's review the layers one more time because it's a pretty complex structure. So from the most internal to the outer layers of the heart. Endocardium lines the inside of the heart. That lining is continuous with the valves and the blood vessels. The myocardium is the thickest layer. That's the heart muscle that allows it to contract. Then the epicardium is the outer layer of the heart, but it's the same thing as the visceral pericardium. Remember, visceral means organ. Pericardium, peri means around, so this is the sac that surrounds the heart. The next layer is the pericardial space that contains pericardial fluid, and the purpose of the fluid is to reduce friction. Then we have the parietal pericardium, and then finally the outermost layer of the pericardium is the fibrous pericardium, which is not stretchy and it doesn't allow the heart to expand beyond its limits. And it anchors the heart to its surrounding organs. So what happens if the membranes of the pericardium become inflamed, or if the pericardial fluid doesn't do its job? Then you can end up with something called pericarditis, and this is inflammation of the pericardium. This roughens up those serous membrane surfaces. If the beating of the heart causes inflammation, or if there's an infection, the surfaces of the pericardium start to rub against each other. And this creates a rough or creaking sound, which we sometimes can hear on our stethoscope, and it's called a pericardial friction rub. Pericarditis is characterized by deep pain to the sternum. Over time, it can lead to adhesions where the visceral and parietal pericardia stick together, and it can actually impede cardiac activity. In severe cases, large amounts of fluid can seep into that pericardial cavity, and this excess fluid can actually compress the heart and limit its ability to pump. This condition is called cardiac tamponade. Tamponade means to compress or to smother. And to treat a cardiac tamponade, you can insert a syringe into that pericardial cavity, into that pericardial space, and drain off the excess fluid. So pericarditis is the inflammation. The pericardial friction rub, or just friction rub, is the sound you hear, and it sounds like sandpaper. It sounds like and cardiac tamponade is when the heart begins to smother because it's being compressed, because remember that fibrous pericardium doesn't stretch. And then in order to treat that, we do a pericardial centesis in order to get that fluid out. Okay, so let's talk about some heart function. We mentioned that the heart is a pump. It works as a double pump. So we're going to talk about the chambers of the heart here in just a minute, but the heart is divided into two sides, the right side and the left side. The right side of the heart receives blood from the body and pumps it to the lungs where it picks up oxygen. We refer to that as pulmonary circulation. The left side of the heart receives blood from the lungs and pumps it out to the rest of the body. We refer to that as systemic circulation. It's pumping blood to the rest of the system. And you can see that here. So over here, the right side of the heart receives blood from the body. It takes that deoxygenated blood, represented by blue, takes the deoxygenated blood from the body, pumps it to the lungs where it picks up oxygen. It changes over to the color red here, pumps it to the left side of the body, or to the left side of the heart. The left side of the heart then takes that oxygenated blood, pumps it to the body, and we refer to that as systemic circulation. So that's what we mean when we refer to the heart as a double pump. So the heart has 4 chambers, 2 atria and 2 ventricles. So the upper chambers are the atria. They receive blood into the heart. So the atria are the receiving chambers. The ventricles are the lower chambers, and they pump blood out of the heart. So the atria are the receiving chambers, the ventricles are the pumping chambers. They push blood out of the heart. A septum is a wall. A septum is just a wall that separates the chambers. And there's 2 septums. One is the interatrial septum that divides the 2 atria, and the other is the interventricular septum, and that divides the 2 ventricles. So here is a diagram of the heart. There is a right atrium, a left atrium, a right ventricle, and a left ventricle. And at the end of this little presentation, you will know all of this circulation and will be able to follow all of these arrows, even though it looks a little crazy and chaotic right now. But I promise you it's not as confusing as it looks. This is my simplified version of that blood flow picture through the heart. So at the top are the 2 receiving chambers, a right atrium and a left atrium. and the bottom is a right ventricle and a left ventricle, and the separating walls in between, the interatrial septum and the interventricular septum. So I'm going to go back to this crazy chaotic picture, and you can see there's a right atrium, a left atrium, a right ventricle, and a left ventricle. And this is my simplified version. So the right atrium receives unoxygenated or deoxygenated blood from two major blood vessels, the superior and inferior vena cava. The superior vena cava returns blood from body regions above the diaphragm, and the inferior vena cava returns blood from body regions below the diaphragm. The right ventricle receives unoxygenated or deoxygenated blood from the right atria and pumps blood through the pulmonary arteries to the lungs. So here's my simplified view. It's very simplified, right? So superior vena cava, inferior vena cava into the right atrium. From the right atrium, that blood is going to pass into the right ventricle. From the right ventricle, that blood is going to pass into the pulmonary arteries and into the right and left lungs. Once the blood's in the lungs, it's going to pick up oxygen, and then that oxygenated blood is going to return to the heart through the pulmonary veins into the left atrium. So the left atrium is going to receive oxygenated blood now from the lungs through the pulmonary veins. So if you learned that arteries only carry oxygenated blood and veins only carry deoxygenated blood, forget that, right? Because here we have veins, the pulmonary veins carrying oxygenated blood, and the pulmonary arteries, a minute ago, were carrying deoxygenated blood. So just remember that veins arrive at the heart and arteries leave the heart. Okay? So pulmonary veins are arriving at the heart and they're carrying oxygenated blood. That oxygenated blood is coming into the left atrium. That blood now from the left atrium is going into the left ventricle. So the left ventricle receives oxygenated blood from the left atrium, and the left ventricle is going to pump the blood through the aorta to the rest of the body. The left ventricle has to pump all of that blood to the entire body. So it has the thickest myocardium because it has to pump blood the furthest. So remember, the right ventricle only had to pump the blood from the heart to the lungs. It doesn't have to go very far. But the left ventricle has to pump the blood with enough force to send it through the entire body. So it has to do a lot of work. So it's the biggest ventricle and it has to do the most work, so it has the thickest myocardium. So here's the representation. Now we have red arrows because we have oxygenated blood. The blood's coming from the pulmonary veins into the left atrium, through the left atrium into the left ventricle, and now my left ventricle has the thickest myocardium. So here's my simplified drawing. Now from the left ventricle, that blood is going through the aorta and out to the rest of the body. Okay, so let's look at it on this complicated picture. Blood is entering from the superior and inferior vena cava into the right atrium. From the right atrium, that deoxygenated blood, remember we're still in blue, deoxygenated blood is going from the right atrium into the right ventricle, and from the right ventricle through the pulmonary arteries into the right and left lungs. While it's in the lungs, it's going to pick up oxygen and return back to the heart through the right and left pulmonary veins. Now it's red because it's picked up oxygen. So from the right and left pulmonary veins, it's going into the left atrium. From the left atrium, it's going down into the left ventricle. The left ventricle, look, it's bigger and thicker because it has to do the most work. So the left ventricle is going to pump it out through the aorta, and the aorta is going to send that now oxygenated blood through the entire body. Okay, so that's the circulation through the heart. So here again, the left ventricle has the thickest layer of the myocardium because it requires the greatest force to pump blood out of the heart into the systemic circulation. So in somebody who has high blood pressure, that causes the ventricle to work harder because it has to pump against an increased resistance. So in high blood pressure, the blood vessels are narrowed, they're constricted, so the ventricle has to squeeze harder to work against that increased resistance. And any muscle that has to work harder is going to increase in size. And that leads to something called ventricular hypertrophy. The muscle increases in size. That's not a good thing because if the ventricle gets bigger, there's less space in the ventricle. So the muscle has to work harder. So that's not a good kind of working harder. So this is what I mean. The normal heart is on the left, and a heart with left ventricular hypertrophy is on the right. So you can see there's not as much space in the ventricle, and the heart will have to work harder and pump more often to push out the same amount of blood. So the heart has to work overtime in somebody with high blood pressure. So it's not a big, strong kind of muscle. It's kind of a big, flabby kind of overworked muscle. Okay, so we looked at that picture with all those arrows and the blood going through the heart. We need all that blood to keep going in the same direction in order for it to pump blood efficiently. So in order to keep the blood going in the same direction, we have heart valves. And the function of the valves is to keep all that blood moving forward. And the valves are found at the entrance and exits of the ventricles. So we have two sets of valves. We have atrioventricular valves that we call AV valves, and those are found between the atria and the ventricles. We also have semilunar valves, which are found at the exits of the ventricles. The AV valves contain cusps or flaps. When the ventricles are relaxed, the cusps are open, and that allows the blood to flow from the atria down into the ventricles. When the ventricles contract, the pressure causes the blood to push those cusps upward into a closed position. And a closed AV valve prevents the backflow of blood into the atria. So remember, in order for the blood to flow, the atria and the ventricle are contracting and pushing the blood. So the cusps of the AV valves, or the flaps of those AV valves, are attached to the walls of the ventricles by something called chordae tendineae. And this prevents the flaps from pushing back up into the atria, kind of like the those metal bars on an umbrella, those metal stays on an umbrella. It's the same kind of thing. The AV valve on the right, between the right atria and the right ventricle, is called the tricuspid valve because it has three cusps. The left AV valve is called a bicuspid valve because it has two cusps. We also call it a mitral valve. So here's a picture of what the valve looks like. So the atria would be above it at the top. The ventricle would be below it. So blood would flow in the direction of the arrow. When the atria contracts and pushes the blood down through the valve, when the ventricle contracts, the blood would push out through the ventricle, the valve would snap shut, and it would meet resistance because the valve is closed and it can't flow back up into the atria. And you can see the chordae tendineae become taut, just like those metal ribs of an umbrella, to keep the cusps of the valve closed. And it keeps the blood flowing in one direction. This is an image of an actual heart valve. So you can see those chordae tendineae there holding the cusps of the valve. The muscles that attach to the chordae tendineae are called the papillary muscles, and they attach to the walls of the ventricle. So this is my simplified drawing again, but showing you where the valves would fit in. And again, these are the AV valves, so they are located between the atrium and the ventricle. And if you can't remember which side is which, you can remember, try it before you buy it. So the tricuspid is between the right atrium and the right ventricle, and the bicuspid or mitral valve is between the left atrium and the left ventricle. The semilunar valves are named because they look like half moon shapes. So semilunar just means half moon. The pulmonic semilunar is sometimes called the right semilunar valve, and that's located on the right side between the right ventricle and the pulmonary artery. When the ventricle is relaxed, the valve is closed, so that blood doesn't passively flow into the pulmonary artery. When the ventricle contracts, it forces the valve open and blood flows into the lung. When the ventricle relaxes, that valve snaps closed. The aortic semilunar valve, sometimes called the left semilunar valve, is located in the left ventricle between the left ventricle and the aorta. When the ventricle is relaxed, the valve is closed. When the ventricle contracts, blood forces the valve open and blood flows into the aorta. When the ventricle relaxes, the aortic valve snaps closed. So here's a picture of the semilunar valves. The pulmonic valve is here. The aortic valve is here. So when the ventricles contract, they will push the blood through this direction. And when the ventricles relax, the pressure of the blood that's in the vessels will force the valves to snap closed. And you can see that here. Here's a picture of the aortic valve. And here is my simplified drawing showing you where the pulmonic and aortic valves would fit in. So they're at the exits of the ventricles. And here's another picture of the pulmonic and aortic semilunar valves, just to give you an idea of how they fit in with the other valves. And you can see the two AV valves, the tricuspid and the bicuspid or mitral valves. And notice that the AV valves have those chordae tendineae and the semilunar valves do not. And here's yet another picture showing the semilunar valves and the AV valves. The mitral valve gets its name from the term mitre. The bishop's hat is a mitre, and it gets its name for the shape of the bishop's hat. Some disorders of valves that you may come across, a narrowing of the valve is called stenosis. That makes it harder for blood to be pushed through. It increases the workload of the pumping chamber. So obviously, if the valve is too narrow, then the chamber that is pushing the blood through that narrowed space has to work harder to push the same amount of blood through it. If the cusps or flaps don't close correctly and the valve does not seal correctly, we refer to that as a valvular insufficiency or valvular regurgitation. This allows blood to backflow or leak back into the chamber that's already pumped the blood. So it causes the chamber to pump the same blood over and over again, which increases the workload of the heart. So valvular insufficiency or regurgitation, again, causes an increased workload for the heart. So like I said, heart sounds are caused by the closing of the valves. An abnormal heart sound can be caused by faulty valves. We call these murmurs. So some murmurs are what we call innocent. These can be seen in healthy children, and it's just caused by fast-moving blood through the heart. Some murmurs may be caused by that valvular insufficiency, meaning the valves aren't closing correctly and the blood is flowing backwards through the heart and being pumped over and over again. So some are innocent and some are signs of insufficiency or regurgitation. The heart sounds are the lub-dub that you hear through a stethoscope. The first heart sound, that doom, 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 that lub-dub, the first sound is called an S1. That's caused by the closure of the AV valves during ventricular contraction. The second sound is the dub sound. We call that S2. That's caused by the semilunar valves closing, and that happens at the beginning of ventricular relaxation. Any extra sounds can be caused by the rapid flow of blood into the ventricles, and we call that a S3 or S4. The S just stands for systole or contraction. If both of those are present, S3 and S4, we call that a gallop. We call that sound a gallop. So a normal heart sound would sound like doom 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 doom. An abnormal heart sound may sound like doom 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 or doom 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 doom. If both are present, it literally sounds like doom 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 doom. Murmurs sound more like a swish, like shh doom shh doom shh doom, or doom shh doom shh doom shh doom shh. And that's my impression of heart sounds. And I'm sure there's a lot of YouTube videos or sound bites on the internet that can do a much better job with murmurs and heart sounds than I can do for you. So we did a little bit of the pathway of blood flow through the heart, but let's go over that again, because if you understand the pathway of blood through the heart, it's really easy to figure out the pathophysiology of what's going wrong, especially in cases of things like heart failure or hypertension or things like that when it goes wrong. So this is the basic pathway. Deoxygenated blood enters the right side of the heart. It flows to the atrium, through the tricuspid valve, then the right ventricle, through the pulmonic valve, then the lungs, picks up oxygen, returns to the left side of the heart. Oxygenated blood goes to the left atrium, through the mitral valve, to the left ventricle. The ventricle pumps blood out the aortic valve to the rest of the body. So here is my very simplified box version of the heart, right? Simple, simple, simple. So where does blood enter? Where does it come into the heart? Superior and inferior vena cava, right? Superior and inferior vena cava. From regions above the diaphragm, it goes to the superior vena cava. Regions below the diaphragm, inferior vena cava. It enters through the right atrium. Then it goes through the tricuspid valve into the right ventricle. From the right ventricle, it goes through the pulmonic valve. From the pulmonic valve, it goes out to the pulmonary arteries, and the pulmonary arteries to the lungs, where it picks up oxygen. From the lungs, the oxygenated blood now goes to the pulmonary veins. Pulmonary veins send it to the left atrium. From the left atrium, it then passes through the bicuspid or mitral valve to the left ventricle. From the left ventricle, it goes through the next valve, which is the aortic valve, out to the aorta, into the rest of the body. So there's your pathway. So here's another little animated pathway. To the lungs, left atrium, ventricle, aorta, body. Okay, there you go. Here's the complicated picture again that I showed you the first time. And like I said, it's not so complicated now if you understand all the parts, right? I put it in that really simplified box diagram. All right, so if you look at this and think of them just as boxes and lines, it's not that complicated. Superior and inferior vena cava, right atrium, tricuspid valve, right ventricle, pulmonary arteries, lungs, pulmonary veins, left atrium, bicuspid or mitral valve, left ventricle, aortic valve, aorta, body. Boom, you did it. This is something that I did for a student a while ago because she just wasn't getting the boxes. But I said it's like a big circle, right? It just keeps going around and around. Your blood's circulating around and around, and it's kind of just one continuous cycle. So I did this for her, and she got it finally when I did it this way. I'm like, a blood cell can jump in this circle anywhere. We're going to start at the body, and you can jump in anywhere and follow this circle, right? So the blood cell enters the body, and then just follow the circle around, right? Here you go. Start at the body, right atrium, tricuspid valve, right ventricle, pulmonic valve, pulmonary artery, lungs, pulmonary veins, left artery, bicuspid or mitral valve, left ventricle, aortic valve, aorta. Back out to the body, and the circle starts all over again. So there's just another representation or another way that you can do the same cycle of the pathway of the blood through the body. Now, if you guys were in my classroom and we were doing this as part of our A&P class, I would do all kinds of games. We would do this, we would be up out of our seats, we would be throwing a beach ball around, we would be doing cards, we would be playing this baseball game, we would be doing all kinds of stuff to do this. But this is a video, so you just have to listen to me talk. Sorry. Okay, so let's talk about the blood supply to the myocardium. So the analogy I use is, you know those big tanker trucks that carry gasoline to refill the tanks at the gas station? They have this big tank of gasoline on the back of the truck, but that gasoline doesn't run the engine of the truck, right? They have to have a separate tank of gas to run the engine of the truck, even though they're hauling all this gasoline on the truck itself. That's kind of like the heart, the way the heart gets its blood supply. So it's pushing all this blood through the chambers of the heart, but that blood doesn't actually supply the heart muscle itself. So the myocardium, the heart muscle itself, needs its own fuel. It needs its own blood supply in order to continue working because it can't get blood to feed the myocardium from all the blood that it's pumping. So the coronary arteries supply blood to the myocardium. So the coronary arteries are the blood supply to the myocardium. Corono comes from the Greek word for crown. And the main coronary arteries are the left coronary artery and the right coronary artery. The left coronary artery divides into two major branches. The left anterior descending is also known as the anterior interventricular artery, and it supplies the interventricular septum and the anterior walls of both ventricles. The circumflex artery supplies the left atrium and the posterior walls of the ventricle. The right coronary artery also has two branches. The right marginal artery supplies the left lateral side of the heart, and the posterior interventricular artery or posterior descending artery runs to the apex of the heart and supplies the posterior ventricular walls. Somewhere near the apex, this artery merges, we say it anastomoses, with the left anterior descending artery. The branches of the right coronary artery supply the right atrium and nearly all of the right ventricle. The coronary veins run parallel to the coronary arteries, and they collect the deoxygenated blood from the myocardium. They empty into something called the coronary sinus, which dumps into the right atrium. So here's a basic picture of the distribution of the coronary arteries. There's many variations and anastomoses of these arteries. The fusing networks of arteries provide additional, or what we call collateral routes, for blood delivery to the heart muscle, but there's not enough to protect the heart completely if a coronary artery suddenly becomes blocked or occluded. This blockage, as you probably know, will lead to first ischemia and eventually infarction, which we're going to cover here in just a second. Here's another picture. The left is the anterior view, the right is the posterior view of the coronary arteries and their blood supply to the myocardium. The left anterior descending artery, or the LAD, is sometimes called the widowmaker because blockage of that artery knocks out so much of the ventricular blood supply that it has a high rate of mortality associated with it. So coronary blood flow can increase and vessels can dilate to allow greater blood flow to provide more oxygen to the myocardial tissues. And like I said, these coronary arteries can form multiple connections between arteries or anastomoses. And coronary blood flow is greatest during myocardial relaxation because when the myocardium contracts, those blood vessels are compressed. So this is important because in somebody who has cardiac disease, when their heart is overworked, blood supply to their myocardium decreases when their heart is working. So they experience chest pain with little exertion. Because if their workload of their heart increases, say they walk for a short distance, their heart rate goes up, the blood supply to the heart muscle goes down. So that's why somebody who has angina, for example, they walk for a little bit or they go up a flight of steps, they start having chest pain because their heart rate goes up, they're not getting enough blood flow to their coronary arteries. And it's relieved with rest because now they've brought their heart rate down and their blood flow to their coronary arteries has increased. And although the heart represents only about 1/200th of the body's weight, it requires about 1/20th of the body's blood supply. So it is disproportionate in the amount of blood that it requires in order to function. So ischemia occurs when tissues are deprived of oxygen. When a coronary artery becomes occluded or blocked, or if the vessel goes into spasm, it can cause ischemia because blood flow can't reach any tissue that's distal to the spasm or past the point of the spasm or the blockage. Angina is the pain that's caused by this blockage. And we give something like nitroglycerin or we have the person rest because that will cause the blood vessel to dilate or allow the blood vessel to dilate, which will restore the blood flow to that coronary artery and decrease the oxygen demand of the heart. So this is just a picture of angina, which is just a type of chest pain or pressure. This is just showing you coronary artery stenosis, which is a narrowing of one of the coronary arteries due to either a plaque in the artery wall or a blood clot. If the ischemia continues, it can lead to infarction, and infarction occurs when the myocardium actually dies because it has been without oxygen for too long. We refer to it as a myocardial infarction if it occurs in the myocardium. And as I mentioned in the very beginning of this presentation, myocardial cells do not reproduce. They stop reproducing very early in life. So once myocardial tissues die, they don't reproduce, so they don't repair themselves. And those dead cells will leak enzymes, which can be measured to calculate the time and the extent of the myocardial damage. So things like a CK or CKMB and a troponin are the lab tests that we do to calculate the damage that's been done during a myocardial infarction. The other thing we do is an EKG. So why do we do an EKG? We do an EKG because we're looking at the electrical signals that travel through the heart. So let's talk about the electrical conduction system of the heart. So that was a good segue into the electrical conduction system of the heart. Okay, so the cardiac conduction system is unique to the heart. Cardiac muscle displays some special anatomical features that reflect its unique blood pumping role. Cardiac cells are really awesome because they have some special unique characteristics. They are self-excitable. They have a property called automaticity or autorhythmicity, which means they can spontaneously contract without being innervated by a nerve. They can contract as a unit, so they form something called a functional syncytium that allows a wave of depolarization to travel from cell to cell and allows them to contract together as a unit. So either all fibers in the heart contract as a unit or the heart doesn't contract at all. And cardiac muscle depends greatly on oxygen to function. Unlike skeletal muscle, which can contract for prolonged periods using anaerobic respiration, the heart muscle requires oxygen in order to function. So like I said, the heart is able to generate electrical signals that travel a specific pathway through the heart. They are able to provide their own stimulus for contraction, and they are able to coordinate contraction between the atria and the ventricles. So this is a list of the parts of this conduction system through the heart. The sinoatrial node, the atrial conducting fibers, the AV node or the atrial ventricular node, the bundle of His, and the Purkinje fibers. The SA node is the first stop on this pathway through the heart. The SA node is located in the right atrial wall, just inferior to the entrance of the superior vena cava. It generates impulses about 75 times every minute, and it sets the pace for the heart as a whole because no other region in the conduction system or the myocardium has a faster depolarization rate. For this reason, it's called the heart's pacemaker, and we call its characteristic rhythm sinus rhythm, and that's what determines the heart rate. So here is a picture of the SA node or the sinoatrial node located high in the right atrium. Next are the atrial conducting fibers, and these fibers carry the cardiac impulse from the SA node through both atria. The impulse travels along these atrial conducting fibers and then it reaches the AV node. The atrial ventricular node or the AV node is located in the inferior portion of the interatrial septum, just above the tricuspid valve. At the AV node, the impulse is delayed for about 0.1 second, which allows the atria to respond and complete their contraction before the ventricles contract. This allows the ventricles to fill with blood. Remember, an electrical signal is way faster than a muscular contraction. So the AV node, the job of the AV node is to slow down the electrical signal. It acts like a gatekeeper. It's like when 4 lanes of traffic slow down to 2, it allows the blood to flow from the atria into the ventricle and collect in the ventricles before it gets pushed out to either the lungs or the rest of the body. So the AV node slows down that conduction. So there is the AV node. From the AV node, the cardiac impulse travels to something called the His-Purkinje system. So the cardiac impulse travels down this bundle of His, which divides into the right and left bundle branches. And these bundle branches send out long Purkinje fibers throughout each ventricle. The ventricles depolarize rapidly, and this causes a coordinated contraction by both ventricles. So here's a picture of the whole system. The SA node, the atrial conduction fibers, the AV node where the impulse is slowed down, the bundle of His, the right and left bundle branches, the Purkinje fibers, and then the Purkinje fibers go into each ventricle. Once those Purkinje fibers depolarize, the ventricles will contract and cause the ventricles to squeeze and push the blood out into the lungs or out into the body. So I mentioned that these are the functions of the muscle cells. So automaticity refers to cardiac impulses that arise from within the cardiac tissue, pacemakers that create electrical signals with no help from the brain or other nerves. So why is this significant? So if you think about somebody who needs a heart transplant, that's pretty significant because the transplanted heart doesn't need to be rewired into that recipient's brain. The heart can just be transplanted into the patient's body and it will start to beat on its own. Rhythmicity refers to the cardiac pacemaker cells that fire in a regular pattern. If that pattern is disturbed, the heart is said to be dysrhythmic or having no rhythm or an abnormal rhythm. Arrhythmia means without rhythm. Dysrhythmia means an abnormal rhythm. Some dysrhythmias are harmless and some are lethal. So here's an explanation of dysrhythmias. Tachydysrhythmias. Tachy means fast. So a tachydysrhythmia is too much electrical activity. It's a fast rhythm. It's a fast abnormal rhythm. A bradydysrhythmia is a rhythm that's too slow. So if you use these terms, tachycardia is usually a fast heartbeat above 100 beats per minute. Bradycardia is a slow heartbeat, usually less than 60 beats per minute. These are kind of fluid in their terminology. If we're talking about bradycardia, usually we say 60 beats per minute, but only if it's symptomatic. If they're 60 beats per minute, but they're not having any symptoms, it's probably fine. But if they're, 50 beats per minute and they're short of breath, then it's really a bradycardia. Ectopic pacemakers. So ectopic just means in an abnormal position. So the SA node is normally the pacemaker for the heart. If the SA node fails to function, then the next stop down the line will take over as pacemaker. So dysrhythmias occur when other sites take over as those pacemakers. We call that an ectopic focus. So if the SA node doesn't work, then the next stop down the line would be the AV node. The AV node will take over and be at about 40 to 60 beats a minute. We call that a junctional rhythm because it's at the AV junction. So that's obviously bradycardia, and some people are fine with that, but if somebody has heart disease, they may not function so well with a heart rate of 40 to 60 beats per minute. So they'll be bradycardic and have an ectopic focus. If the AV node fails to function, then the ventricles can actually take over and function as their own pacemakers, but the ventricles will only be at very slow, maybe 40 beats per minute. So that's not good. They will need a pacemaker implanted in order to keep their heart functioning. So they can live for a little while with their ventricles functioning for them, but they can't live for very long with their ventricles functioning as their pacemaker. So how do we know what's going on with the electrical system of the heart? We do an EKG or an electrocardiogram. And I'm sure you're all familiar with these, right? The electrocardiogram will record the electrical signals in the heart. And this records electricity, not muscle contraction. So you can have, in certain cases, electrical activity, but no muscular response. So just be aware of that. What's going on electrically may not be what's going on physically. The heart muscle may be too sick to respond to the electrical activity. So an electrocardiogram, an EKG, or an ECG has certain components: the P wave, the QRS complex, and the T wave. The P wave indicates atrial depolarization, an electrical signal that's going through the atria. So if the P wave is present, that means that the electrical signal is arising from the SA node. We call this rhythm a sinus rhythm. The QRS complex indicates ventricular depolarization, and the T wave indicates ventricular repolarization, or ventricular resetting, if you will. We don't see atrial resetting or atrial repolarization because it occurs during ventricular depolarization and it gets buried or lost in the QRS complex. And an EKG is important for us to read because remember we said that myocardial cells don't repair themselves, they don't reproduce, they don't repair themselves. So if there's been damage from ischemia or infarction, those muscle cells are going to be damaged and they may have some scar tissue or fibrosis, and damaged myocardium does not conduct electricity in the same way. So we will be able to see those changes on an electrocardiogram. And if the person is actively having a heart attack, that tissue is not going to conduct electricity the same way. So we will be able to see that information on an electrocardiogram. So here's an image of just one heartbeat on an EKG. So a P wave, again, is atrial depolarization. The QRS complex is ventricular depolarization, and the T wave is ventricular repolarization. And we can measure all kinds of things here. We can measure how high the waveforms are, how wide the waveforms are, and how much space is in between each waveform, how much space is in between each part of the waveform, and we can get a whole lot of information from this simple tracing of the electrical output. So a 12-lead EKG is done to look at 12 different angles of the heart to give us a complete picture of the heart. So you can see here 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Here's another EKG, and you can see the waveforms are a little bit closer together. This is showing tachycardia or a fast heartbeat. And again, the 12 different leads, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. And the row across the bottom is giving us 6 seconds of one lead to give us a longer reading of just one view. This is showing us sinus bradycardia, and you can see how far apart the waveforms are. So this is a much slower heartbeat. And this EKG is just showing us changes that you would see with ischemia or infarction. You can see how the waveform changes with different injury patterns. And you can see how the QRS complex changes and the T waves change with different injury patterns. Here the T wave is upright, here the T wave is inverted, here the T wave is more depressed, here the QRS complex is more elevated. So we can tell a lot just by looking at the shape of the waveforms. Here's an example of something called atrial fibrillation. This one tells us that the atria are not contracting. The P waves, remember P waves told us that the sinoatrial node was contracting and the atria were contracting nicely. Here there's no distinct P waves, so the atria are just kind of quivering or fibrillating and not really doing a good job of effectively contracting and pumping the blood into the ventricles. And the QRS complexes are not uniformly contracting, they're not evenly spaced. So this is an irregular dysrhythmia called atrial fibrillation. This is a dysrhythmia called premature ventricular contractions. You can see these weird looking contractions that just kind of randomly show up. They're called PVCs, premature ventricular contractions. This is a scary rhythm called ventricular tachycardia, where the ventricles are contracting very quickly, and this is a very concerning rhythm because it may evolve into this, which is ventricular fibrillation, where there is no coordinated contraction of the ventricles. Basically, the heart is just quivering. The patient will have no pulse and needs to be defibrillated very quickly because this is not sustainable with life. This is an EKG showing atrial fibrillation that went into something called asystole. Asystole was no electrical activity, and then she picked up 1 or 2 heartbeats at the end there, She ended up being diagnosed with sick sinus syndrome and ended up needing a pacemaker. And this is what a pacemaker looks like on an EKG. You can see where the arrows are. Those straight lines are electrical impulses from an implanted pacemaker, and you can see the pacemaker goes off, and then what follows is the ventricular depolarization that was caused by the pacemaker. And that is all I have for you. I thank you very much for your attention. I hope you were able to pick up one or two tips from this review session, and I hope you enjoy the rest of the sessions that are offered to you during this conference. Thanks.